Hi, Kate Grace, physical therapist, orthopedic physician assistant. Welcome to Move Without Limits podcast. I hope a lot of you saw Henri's podcast last week because he was a perfect example of what we're going to talk about today, getting the right treatment quickly and get a quick resolution of your pain or dysfunction. We're going to talk about the most common orthopedic injuries today, and what it means when it hurts here or here, and how do you fix it. Let's start with back pain. Very, very common. In the spine, we've got lots of places where it can be a challenge. So there's one thing that's very, very common called mechanical low back pain. And that means when you've got pain across your back, it might be one side more than the other, but it sticks to your back. It doesn't go up or down. And that's because in your spine, you've got joints. And between each vertebrae, there's two bones that rub against each other. And those are where the joints are. And they can get stiff, they can get arthritic over time. And it's a tough thing to treat. But like most of the things I'm going to talk about today, very amenable to physical therapy, mobilizing your joints, making sure there's not abnormal stressors or predisposing factors on your spine. The second and probably most common thing is a herniated disc. That's when some of this disc material protrudes out through, it's called a foramen, the hole where your nerves come out. So what happens here is that disc material pushes against the nerve, and that results in pain, tingling, numbness, sometimes swelling down your leg in the distribution of whatever nerve that is. So we can pretty much tell what nerve is involved by where your symptoms are. Again, very amenable to physical therapy, opening up that space in there with manual therapy and mobilizing the joints and making sure that the nerve has as much space as possible. There's so many things that can cause back pain. Most of the time, it's repetitive use over time, like golf. You know, we're not meant to rotate our spine that many times in the golf swing. So what you have to do is prepare it to do that and also unwind it. So if you're a right-handed golfer, I would suggest doing a lot of left-handed or left-sided rotation. Make sure you warm up great before golf and make sure that you stretch afterwards. You have to have your core very strong. And one of the most important things in golf that you need is flexible hips, because when we swing the golf club, we rotate one of our hips internally, the other externally, and when we come back, we do the opposite. That's where your motion, your trunk motion, that's where your power should come from as you push off the ground and rotate. And this can be any rotational sport, not just golf. But let's say that your hips are too tight and you can't quite get over there, that perfect position where you want to be, but you know you want to get there. Where are you going to get it from? Right here. You're going to overuse and over rotate your little spine. And you can tell these little joints are not as robust as your big hip joint and really can't take the stress and strain, particularly on the nerves as they exit the spinal cord. So those are the most common for the back, the lumbar spine, and that's what this looks like. The cervical spine or your neck can have the exact same things happen. Right between the joints here and the facet joints, you can have arthritic changes and wearing down of the cartilage leads to what's called stenosis or lack of movement in each vertebrae. In your neck, though, it's really important and it's a little bit easier to mobilize because the vertebrae are smaller. It's easier for the therapist to get their hands on them. Your neck should be concave like this. So it should be lordotic or concave. Then your thoracic spine, your mid-back, should be rounded or kyphotic. Then your lumbar spine goes back in, lordosis or concave, and then your sacrum goes back out. So if all these are in normal alignment and equal and great range of motion, then you don't have any abnormal stresses on your spine. But with all the activities we do with our neck, what position is your head in when you read? Forward. What is it when you're working on your computer? What is it when you're talking to someone? What is it when you're doing a sport? Your head's always forward. So it takes that nice curve of your neck and flattens it. As the cervical spine flattens, it decreases that space where the nerves come out and sets you up for arthritic changes between the joints and impinging the nerve as it exits. So again, physical therapy. A lot of times people said, "Oh, I've got this like really bad muscles, really tight muscle in my back, or my neck muscles are really tight." Well, in order to hurt one of those muscles, you probably have to jump off a 4-story building. So what happens is when there's abnormality in the spine, whether that curve changes or you've got too much pressure on different areas of the spine, then your muscles react by tightening around it so it doesn't hurt it further. It's just like spraining your ankle. What happens when you sprain your ankle? It gets swollen. Why? Because it doesn't want you to sprain those ligaments any further. So it's usually not a muscle, and if you go and get massage, which is great, or you go get some temporary treatment, it can feel good for a little bit, but it's not going to feel good long term. So what we have to do is, again, the whole point of today's episode is getting to the cause of the pain. So when we do a thorough examination, we can get to what the actual cause, what structure is causing your pain. Because when you have a herniation and you have leg pain, I've had patients come in, they often say, "Oh, I really have this really bad glute pain, or I have this, my thigh pain. I must have hurt my leg somehow." Well, it could be, but if you examine them properly, then you'll find that it often is coming from the lumbar spine or the neck, or my shoulder hurts. It really hurts right here. Well, your deltoid's a big muscle, and in order to hurt that, you would have to get, punched in the boxing ring or something. What happens is that C5 nerve root refers pain down into the shoulder. So I've had so many patients who have complained of shoulder pain, but it's actually coming from the neck. So a thorough exam, not a 5-minute or a 2-minute or a 1-minute quickie exam, is not going to find it. So make sure you find somebody who will do a thorough exam and determine the cause of it. The next most common area that we see orthopedic injuries is in the knee. There can be so many things wrong in the knee. You can just bend your knee and straighten it and pinch what's called the synovium around it, or the capsule. It's highly innervated with nerve endings. You can pinch that and your knee will be sore and swollen. It doesn't mean you hurt a major structure, but it can be sore and swollen. So to treat that, again, examine it. That usually, with a very few treatments, loosening up that tissue, making sure that the joint range of motion and position of everything in the joint is normal, usually goes away pretty quickly. What else can you hurt? Your meniscus, your little bushings right here in between your femur, your big long bone, your thigh bone, and then your tibia, this one down here. So you don't want to have bone rubbing on bone. So what happens is that these were put here, these big cartilage. So they're called meniscus. Go one on the inside, outside. You can get tears in these. Now, part of the meniscus has circulation in it, so it can heal. Other parts do not, harder to heal. What does it feel like? Well, you can sometimes I've had patients say it hurts right there. Like you can pinpoint that right on the joint line on either side for the meniscus. It also hurts with prolonged activities. Like it feels fine for a while, but then at the end of maybe the second hour of pickleball or the 15th hole of golf, it starts to hurt. It also hurts with lateral movement. So lateral movement does not feel very good on the meniscus. Now, we used to fix those all the time in surgery, but now, if you didn't hear Dr. Rogers' podcast on regenerative medicine, go back and listen to that. But now we inject these with PRP, and the growth factors in the platelets of the blood can actually heal that tissue. So we really don't do it hardly anymore. There's maybe one instance, it's called a flap tear, where the cartilage can tear enough where it flaps up and your knee locks in one place and you can't unlock it. That's a more serious symptom. Sometimes that needs to be fixed. But if you just do an injection of PRP, you don't have all the risks of surgery. You don't have your knee blown up with a bunch of fluid that you have to rehab and recover from. You don't have an anchor and a suture in there that can work its way out. You actually heal the tissue. So if you have questions about that, please go back and watch Dr. Rogers. And then I did a subsequent live on regenerative medicine that I think you'll find really helpful, because it's been amazing over the last, I don't know, 10, 15 years, maybe 20 years now, that we've been able to fix a lot of these things with a very low risk injection that naturally it comes from you, from your blood. And then the other thing you can do is tear your ACL, which is this big ligament right here in the middle. And its job is to stop this motion from happening in your knee. So it stops the shift or movement translation anterior and posterior of your femur and your tibia. Oftentimes, this is a traumatic event, and it's sore, it's swollen, it pops, and it's very painful. You do not need surgery if you have a partial tear. You should be able to get better with physical therapy doing that. And if you have a complete tear, then yes, sometimes you need a reconstruction. But there's a lot of people walking around out there with partial tears of their ACL. How does it feel to you? It feels unstable. It feels like you're walking along and your knee shifts, which it does, or it pivots, which it does. So lateral, fast stop, start, pivot motions, rotation is not going to feel good to you on your knee. So again, make sure you get a great examination. And then the last big one in the knee is called patellofemoral dysfunction. And that's when your kneecap or your patella is not riding in this groove where it's supposed to be. And it may be off to the side, rubbing on a bone. And you can get pain under your kneecap, around your kneecap, inside, outside, above, below. And this usually is a symptoms and dysfunction over time. It's usually not a traumatic event, although you can get a dislocation or a subluxation of your patella. When does this hurt you? Usually activities that cause an eccentric or a deceleration to the knee, like walking down a hill or a mountain, walking downstairs, doing a squat, even prolonged sitting. This is something we do not want to operate on. This is something that you need to go to a really good physical therapist who knows how to treat this, get your kneecap back over where it's supposed to be, and then strengthen the muscles to keep that alignment normally where it is. So this is a very common in young teenage girls especially, but if it's treated right at that age, then it can get better. It's one of the few orthopedic problems that can get better with age. A lot of other things don't, leading to arthritis and things like that. So those are the main things in the knee. And then the shoulder, all kinds of things can go. You can get shoulder pain in a lot of different areas, but the most common is called a shoulder impingement. And what happens is, this is your shoulder joint right here. This is your scapula, your shoulder blade, clavicle or collarbone. And what happens is, you can see that here's your bone in your arm, and here's a bone that's attached to your shoulder blade. When your shoulder, which a lot of us are because everything we do is forward, it rolls forward and it shortens that space between those two bones. What happens then is called an impingement. So this bone impinges on that bone. Typically, how do you know you have this? Well, it hurts when you go up overhead. It hurts when you go behind your back. It hurts when you cross your hand over the opposite shoulder. And we want to kill this beast when it's little, because if you don't fix the impingement, then what goes through there is your rotator cuff tendon. And so the next step, if this isn't treated, it's rotator cuff tendonitis and then a rotator cuff tear. So let's not let it get to that point. Lots of times you'll feel the pain right here. Right there in the front of your shoulder. And that's where you're getting that smaller space between these two bones. How do you know you've torn your rotator cuff? Well, your rotator cuff are 4 muscles. There's 3 on the backside of your shoulder blade and 1 on the inside. And what they do is when they contract together, that's why there's some in the front and some in the back. When they contract together, they create a cuff, and they push your shoulder bone, this one, down. And so when they do that, then you can freely lift your arm in all different degrees of motion without pain or dysfunction, because they're doing their job. But what if you have a partial rotator cuff tear or a full rotator cuff tear? If you do this and hold your arm out here, and you can't do that for 10 seconds or more, and your arm falls down, you might have a rotator cuff tear. If you get your arm to a certain point and you go, I can't lift it any further, so I have to use my shoulder blade, which you don't want to do, and lift my arm up, that could be a rotator cuff tear. So partial rotator cuff tears, we can inject again with PRP and heal it. And full thickness, sometimes you have to have surgery. So if you have any pain right here in your shoulder, now it could be biceps tendon. That's not as common as an impingement, but that also is right here in the front of your shoulder. You can get rid of it with exercises, and I'm going to show you a couple of those in a minute, that we do in our class with a band. Get on a foam roller and open up your shoulders. But just think of all the time that you spend like this, like everything. And so if you look at yourself and you see your hands look like this instead of like this next to your body, that means your shoulders are rolled in. So make sure you get them back there. We do a ton of upper back strengthening in our class just for that reason. And it's not like I want you to get huge upper back muscles. I want you to undo this. The next big joint that we find a lot of problems in is the hip. And I'm going to tell you a story about a guy because I know there's more people out there that have this symptom, and I do not want you to wait to seek help. This young guy was 24. He just got done playing basketball, and his groin hurt afterwards. And he thought, oh man, I really strained at playing basketball. Shoot, I'll ice it and take some aspirin or anti-inflammatory. And he rested it, which is not the best treatment, rest. And went down a little bit. And a couple of weeks later, went back to play, and it was still there. And he thought, oh shoot, I really must have hurt it. I'm going to wait. So he waited several months, wasn't going away. And his mother said, you have got to go get a scan. He went and got a scan, and he ended up having testicular cancer. The cancer from the testicle does refer into the groin. Similarly, talking about the hip, if you have hip pain or hip osteoarthritis or shortening of the joint space in the hip, it can mimic itself as groin pain. So groin pain is often not groin pain. It's often something else. So if you have that, please seek help sooner than later. He ended up having his surgery to have his testicle removed, but because he waited so long, it metastasized into his hip. It got all through his hip joint, all wrapped around his muscles, and all wrapped around his blood vessels. It was an 18 centimeter tumor, which is very large. So because of that, they said it was inoperable, and the doctors did not think this guy was going to make it, and put him under intense chemotherapy. So he had to have chemo into him 8 hours a day for 4 days on and 3 days off for 3 weeks, and did that for months. He went from 200 pounds to 100 and some pounds. He, of course, lost his hair. He got very, very small, very weak, but it shrunk the tumor. And he's alive. So this was 5 years ago, and just 2 months ago, he got released from oncology, which is really what you want to do, is get released from oncology. So it's a perfect example of thinking, I'm young, this is just nothing, I'll see if it'll go away. I tell my patients, wait a week, just a week. If it's more than a week, there's no reason to wait. Go to somebody good who will do a good exam and give you the right tests. I mean, it's probably not, as severe as his, but it's probably like Caitlin Clark. Here's this famous WNBA player who's got groin and quad pain. What'd they do? I'm sure they treated her. I'm sure they are treating her. And she rested and got treated for a few weeks, went back out and played. It came back. Why? They have not gotten to the cause of her pain. I bet it is not a groin problem. It is not a quad problem. It's something else. It's just like Rolf Benershka, the past NFL kicker for the San Diego Chargers. If you haven't seen his podcast, it was our first one, and it's very inspirational. But Rolf he did die. He got really sick with Crohn's disease. He went in the hospital. He had several surgeries. The last one, they said he went into a coma. He would not back out. His mother said, oh, yes, he will. And he literally died, came back, and he went from 200 pounds to 100 pounds. And his whole goal was, when he got home, was to walk to his mailbox and then walk to the neighbor's mailbox. And then that's what he did. Anyway, he went back. He said, I want to win my job back. So he went back, won his job back with the charge, because he still had years to play in the NFL. And he started kicking and got really bad groin pain. And so for 1 year, the NFL doctors, trainers, physios, etc., worked on his groin, and it didn't go away. Somehow he found me. I'm not sure how. And when I did an exam, now when someone does an exam on you, here's another thing. When they examine you, they should examine you from head to toe, not just my shoulder hurts here, everywhere. And when I looked at him, he has a scar about this wide, and it goes from here all the way down to his pubic bone, because they had to open him up so many times, and it was all scarred down. Now, if you know anything about the mechanics of kicking, to kick a heavy football 60 yards, you cannot kick it with your little groin muscle. You can't. And so the kicking mechanism is you rotate your trunk as far as you can one day, and you rapidly rotate and twist it the other way, letting your leg trail to kick the field goal. Well, he had about 50% of his trunk rotation. So all I did to fix his groin was I worked on his scar, I mobilized his ribs, I mobilized his vertebrae, I worked on his trunk rotation. We got him full trunk rotation. Then I worked on his trunk rotation strength. And in a matter of weeks, his groin pain went away, and he went back to kicking, and he finished his career in the NFL exactly the way he wanted. So another example of the pain is not always where the cause is coming from. So you have to really think. When I see a patient and I examine them and I think I know what it is, my question I ask myself all the time is, what else could this be? What else could this be? Because there's so many things that can go wrong and affect something else. One guy came to me many years ago. He was 34 years old, and he had been undergoing treatment at another clinic for 6 months. And the diagnosis for his doctor was ankle sprain. Well, his ankle was swollen, and he had some weird symptoms in his lower leg. And he came to see me because he wasn't getting better. So I did a full exam, and I tested his reflexes, and I did a neurologic exam on him, and nothing pointed to an ankle sprain. Absolutely nothing. I thought he had a central cord lesion where there was something pressing on his spinal cord. Immediately, I called a very smart spine surgeon, sent him up to her. She did the same tests I did, found the same things, did an MRI, and found a sacral tumor about this big. We operated on him at 6 a.m. the next morning and took all this tumor out, and it had metastasized, and he was 34 and he died. So I know 6 months earlier than that, I bet his tumor was this big. So again, you got to get the right diagnosis and don't wait. There's a lot of other things that affect how, let's say you've had an injury. There's a lot of things that affect how you rehab. I had these two guys, both in their early 20s, both had ACL reconstructions about the same time. And I happened to be rehabbing them at the same time. So one of them, they would come in and, they became friends. And, our clinic was like a Cheers bar, everybody kind of got to know each other. And one guy was like 3-4 weeks ahead of the other guy. And he goes, hey, how come his knee bends more than mine does, and he doesn't have enough swelling, and he's able to now start doing more things at the gym, and I can't? Well, I ask this question to my classes and students every time I teach. Why do you think that is? And they would say, oh, genetics. And nobody ever got it. The guy that was ahead lived on a boat. And so all day long, he was going like this. He had to right himself. And then I thought, how important is balance and proprioception and coordination? So we started doing tons more of that work when we did our rehab, and it really helped shoot people through a lot quicker. So the other important thing about proprioception and balance is the morbidity and mortality rate. If you're over 70 and you fall and break something, 50% of those people die because they get in the hospital, they get pneumonia, and they die. So we always say friends don't let friends fall and break something. So yeah, like just 2 days ago in our class, in our 50 States class, in our 50 States class, the whole thing was all balance and proprioception. We did it on a pad, single leg, while we worked on strengthening our core a lot and our legs and our arms. So please work on your balance and your coordination and your proprioception. You do not need to lose your balance as you age. You do not. It's not one of those things, well, I'm just getting older. It's not. You can work on it. Just simply standing on one leg. Stand on one leg for a while. Stand on one leg, close your eyes. I mean, it doesn't take a lot to improve your balance and maybe help a loved one, an older person, help them with their balance. Another great place to rehab is the pool. I wrote a paper, my first paper on healing running injuries using hydrotherapy, and I created all these exercises you can do in the pool. And the great thing about the pool is no matter which way you move, you're getting resistance to the joint, to those muscles. So if you put your leg out like this, it's getting the outside of your leg. If you pull your leg in, it's getting the inside. And what's great about that is you're doing all this exercise without the gravitational forces on your joints. So get in a pool, do a bunch of walk forward, walk backwards, walk sideways, do some rotation. You don't have to swim. Oh, I don't like to swim. That's okay. Just get in the pool and move around, because that's a great place to rehab. The other thing, it's so important, is in terms of for your body and preventing injuries, is weight training. Weight training should be a non-negotiable thing in your life once you're out of your 20s. And there's tons of musculoskeletal benefits. You know, I always say your joints are only as good as the muscles that support them. So if you fall, you want those muscles to contract and protect you. You don't want to fall and break something. There's tons of metabolic benefits and brain benefits. We're going to have these really smart doctors on that are going to talk about that in upcoming episodes, particularly the metabolic and brain benefits. But please make weight training a part of your at least 3 days a week exercise routine. We mix it up in class because, like, one day we'll do lighter weights, a lot of reps. Then we'll do heavier weights, less reps. And we'll do this body part more than this body part. And so you have to mix it up. You have to shock your body. You have to, don't do the same. You know, people say, okay, I work out 6 days a week in the gym. Well, what do? It's the same thing. Well, if you do the same thing over and over, your body's never going to change. So don't expect it to. So find somewhere or join us in our class that you can do something where someone figures out your exercise for you in the day. It's over. If you can't join it live, you can always do it later. But you have an exercise plan that shocks your body and changes it every single time. One other thing that people ask me about a lot is hydration. We all live in climates probably where it's pretty warm in the summer and humid maybe, and you're sweating. And a lot of times just water's not enough. So people have asked me, what do you like? So I like, it's made by Noon. And this is During Sweat Endurance. I don't know if you can see that or not. But this is the one I like. It's made by them. And they also have little capsules you can get, but it's a very, very clean, doesn't have chemicals. And I used to get really bad leg cramps, and I don't get them anymore now that I start putting hydration in my water. So those are the most common orthopedic injuries. I promised I would show you a couple things. What we use in our class is we use a resistance band. We also use, this is something you might want to get. It's like a yoga strap, and it's canvas, and it's got loops in it, so it helps you work on your flexibility. But one of the things you can do right away for your shoulders is wrap this up quite a bit, and let me show you this. To get rid of that shoulder, forward shoulder, get it nice and tight, and tuck your elbows in here and push out, just like that, and activate that little rotator cuff muscle that is back there. You can also put your hand on your leg and come back here to 45 degrees. You can push out this way. The other thing I really like a lot for your shoulders is I like you to lay on a foam roller. This is a foam roller. You need the long one, and this is a firm one. You can use a softer one if you want. But if you lay on it head to tail vertically, and you lay back on it, your shoulders have to drop back, and it will get you in a perfect position in extension and get you out of this position. So those are the most common orthopedic injuries. If you guys have questions, please ask. You can ask them now, you can ask them later, and we will answer them. I'm going to move on to our favorite new segment, crazy things I see at the gym. So I know a lot of you don't do this at the gym, but I've seen it so many times. Many people like to get big chest muscles. So what do? Bench press. All right, bench press is fine. If you lay on the bench and you keep your spine connected to the bench and you press up and use your chest, that's fine. But I just saw this again for the umpteenth time. These guys want to lift 500 pounds. So what do? Their whole body comes off the bench and they're lifting the weight with their trunk, not their chest. So they're going up off the bench, up off the bench, up off the bench. So no, that's not how you do a bench press. You should do it connected. And if you got to fight for that last one and have somebody help you, that's fine. But don't engage something else when you're attempting to work on your chest. So crazy things I see at the gym. AKA Ask Kate Anything. I'll ask my lovely producer if we have any questions that you guys might have. And again, if you don't have them now, ask them later and we'll get to them.
Yes, Devin would like to know, how do I know if I should rest my knee or keep moving?
How do I know if I should rest my knee or keep moving? Well, that's a good question. When you do have pain, you don't want, whether it's your knee or another joint, you don't want to reproduce your pain. So if you can go swimming, it doesn't hurt. Great. But if you run, it hurts. Don't run until you get it fixed, because pain is telling you something's wrong. And if you keep irritating it, you can potentially make it worse. Let's say you have a little meniscus tear and you run and it hurts. You could make a big meniscus tear or a rotator cuff or an ACL. So rest is great initially, especially if you have swelling where you're going to ice it, that's fine. But get it treated and don't do anything that reproduces the pain. Like I had patients who could bike with no pain, but they couldn't walk downhill. So yes, biking's fine, but no walking down the hill.
Jackie says, when is shoulder surgery necessary versus when can therapy fix it?
When shoulder surgery necessary or when can therapy fix it? Well, I think that you should, first of all, exhaust physical therapy before you consider surgery. Maybe it's a month, maybe it's 2 months of rehab to see if you can avoid surgery. That's always the number one option, conservative treatment. Number two is a regenerative medicine injection to see if that can heal it, if you have a frank tear of something. And then surgery should be your last option after you've exhausted, because let's say you have a partial rotator cuff tear and you can do an injection. Maybe you're sore for a week. You do maybe a month of physical therapy and you're back doing what you want to do, versus you have a rotator cuff surgery, all the risks, anesthesia, etc. of surgery. Then you have to wait for a while before you can start therapy. Then it's maybe 2, 3, maybe 6 months before you're back. It's same with ACL surgery. So think about, I want to minimize my downtime. So I want to think about doing anything else I can before I entertain surgery.
Sarah says, why does my back hurt after sitting or standing too long?
Why does my back hurt after sitting or standing too long? That's a good question. Because when you sit, it increases the disc pressure and the pressure on your spine by exponentially times 3. So when you're sitting working, I always say to people, get up every 30 minutes, stand up. You can do, I can maybe show you this. Stand up, put your hands in your low back and bend back and push your pelvis forward, just like that, because that will undo this bent forward position. So back like that a bunch of times, and then go ahead and sit back down, because all you have to do is to undo that pattern that your body's been in. Standing, same thing. You have to contract the muscles around against gravity, and it puts abnormal pressure. So you want to change your position frequently, even, lying, standing, lying on the other direction. Oh, the best, I'll tell you this one of our last things here is there's a position called 90-90. So lay on your back, bend your hips to 90 and bend your knees to 90. Think of this as laying on the floor and putting your legs up on the ottoman or the seat of a chair. That 90-90 position with your back flat takes all the weight-bearing forces off your back. So if your back hurts, get down there and I promise you feel a lot better. One more we have time for?
Brian has asked, why does my hip hurt when I sleep on my side?
Why does my hip hurt when I sleep on my side? Good question. Because your pelvis is wider than your knees or the bottom of your legs. So when you lay on your side, your knees are going to be close together. And so when your knees go close together, it pulls on your hip because your leg, instead of at a square angle now, is at a, it's called adduction, but it comes close to the midline. So what happens is as your knees come together, you're pulling on your hip and your back all night. So I tell everybody, whether you've got pain or you don't have pain, sleep with a pillow between your knees, because then instead of your knees being together, they'll be apart, which will mimic your hip joint alignment with your knees. I also suggest a pillow under your arm, up here on top, on the one that's on top, because then your shoulder won't go forward. So I tell people one little one under their head, one between their knees, and one under their arm, and you'll probably wake up with a lot less soreness and stiffness. Okay, well, thank you. I know we went a little long today. Next week, to follow up on this, on back pain especially, I am interviewing one of the best orthopedic surgeon spine specialists. He is super smart. He's a great diagnostician. He's technically really, really good if you do need surgery, and he always does the right thing. He does not do surgery if you don't need it. And if he does the minimal surgery instead of some great big surgery. I know you'll enjoy listening to him, and he's got very similar philosophies to I do in terms of rehab and taking the best care of you. If you have any questions that we didn't get to today, you can always drop them in later. We will check and answer them. And every Thursday, we'll be back next week with a new episode. So stay tuned, and thanks for joining Move Without Limits podcast.